Who's disabled participant screen sharing? So I think you need to let me share the screen, Boon.
I have enabled screen share. Can you?
Host disabled participant screen sharing.
Hey, really? Oh, hang on. I am sorry. Right. Okay, go.
Can you guys see my slide?
Yeah. Do you want to click? Yep. Beautiful.
Can you listen to me? Yeah. Everyone listen to me?
Yeah, probably.
Yes. Hello, everyone. I'm Dr. Prajwal, one of the HIEM trainees. So today I'll be talking about shock patient, management of shock patient in the ED, and also like venous thromboembolism. So in the old curriculum, like it comes under CMP5, and under our new curriculum, it comes under RP7, under RLO Learning Outcome 3. So let me proceed with my presentation. So like under RLO3, like it comes under this category. So shock, like I could not present all the presentation in one day. So it takes around as you can see, like there are 8 RP8. So I'll just be focusing on the RP7 shock. So this comes under RLO3. So objective of my presentation would be to define shock, to discuss different types of shock, to investigate and manage the management of the shock patient. And I'll briefly discuss about the NICE guideline on recommendation on diagnosis and management of VTE diseases. So let's define what is shock. So basically, like shock is a state where like oxygen demand is more than the oxygen delivery. So because of this, like there's circulatory insufficiency, which leads to like inadequate tissue perfusion, and thus delivery of oxygen to tissue of the body, which will also there will be buildup in lactic acid, and which will cause further problems in the body. So categories of shock. So there are basically like 4 types of shock. First is hypovolemic shock. Can anyone from the audience define me what is hypovolemic shock? If that's okay. Anyone? Okay. So shock can be also classified into like a distributive shock, obstetric shock, and cardiogenic shock. So like it can cause from numerous pathophysiological processes. Like I said, like it can be categorized into 3 shock. So irrespective of the cause, it can be classified into 4. So let me describe like hypovolemic shock. So like basically like it's an inadequate circulating volume secondary to fluid loss. So the example of hypovolemic shock would include hemorrhagic such as trauma, GI bleeding, obstetric hemorrhage, rupture AAA, diarrhea and vomiting, also like third space loss, and diabetic ketoacidosis and burns. So distributive shock. Can anyone from the audience tell what's distributive shock? If not, then I'm happy to proceed.
So distributive shock is the one where basically the majority of preload is distributed peripherally, like in anaphylactic shock or septic shock, neurogenic shock.
You're right, Dr. Sushil. So like Dr. Sushil said, and it will lead to inadequate perfusion secondary to maldistribution. So this would include like sepsis, neurogenic shock, and like Dr. Sushil said, like anaphylactic shock. So the other category of shock would be cardiogenic shock. So basically it's inadequate cardiac output as a result of cardiac failure. So what leads to like this cardiogenic shock? So the example of cardiogenic shock, causes of cardiogenic shock are myocardial infarction, myocardial contusion, myocarditis, lead sepsis, overdose such as beta blockers, and complete heart block. So the last, but not the least, it's obstructive shock. So it's a state where like there's inadequate cardiac output as a result of mechanical obstruction. So it could lead to, for example, it's like pulmonary embolism, tension pneumothorax, cardiac tamponade, and acute IVC or SVC obstruction. So how do we manage shock in the emergency department? So always we go for like ABCD. ABCD is the priority. And we initially started by like giving O2 via mask. And we have to get venous access and like take the following required for following blood test for investigation. We have to like hook the patient to the cardiac monitor to monitor vital signs, including pulse, BP, saturation, respiratory rate. We have to check for lactate and then tissue perfusion, like if the patient is hypoxic via AVZ. And also like we need to like connect the patient to we have to get a 2-lead ECG and chest X-ray. If it's possible, we have to like insert a urinary catheter and monitor for like signs of oliguria hourly. So for the shock associated with defective circulating volume, for example, in like a hypovolemic shock, so we can start with initially start with 20 mL per kg bolus normosaline, and in cases of like GI bleed, colloidal blood would be like appropriate according to the etiology and clinical response. So we have to do the we have to be guided by pulse, BP, and central venous pressure and urine output. So like we have to keep on monitoring this, and like it should guide us to the treatment of the patient and management of the shock. So like so we have to use like caution with IV fluid in the cases of ruptured aortic dissection. We should not over give fluid to the patient. So specific treatment includes like a laparotomy for ruptured AAA, splenic and liver trauma, ruptured ectopic pregnancy, and intra-abdominal sepsis. For MI, we have to do thrombolysis or angioplasty. For PE, we have to thrombolize the patient. And for cardiac tamponade, aortic valve dysfunction, like what we can do is pericardiocentesis for cardiac tamponade, and also like cardiac surgery for the aortic valve dysfunction. So for like different kind of poisons like symptomatic management, and also like we have to give antidotes. And for the septic patient, we have to give like broad spectrum antibiotic if we do not know the cause. And we should always aim for goal-directed therapy. So like if the patient's BP is like a low, and like we have to like look for like think about using inotrope and vasoactive therapy. And if the patient is critically sick, then we can think about assisted ventilation and invasive monitoring, including arterial line and CPP line. We have to get like early ITU input in this kind of patient, and patient should be like swiftly shifted to ITU for further management. So let me discuss a case. We have like a 40-year-old female came in with a complaint of acute shortness of breath and central chest pain. So like on a history, like patient is mildly febrile, heart is racing, systolic BP is low, patient has a low saturation, and patient has a tender cough. So like we have given like all the fluids, oxygen and antibiotics, but the patient is getting worse in front of us. So we have done like initial investigation, and the chest X-ray was clear. D-dimer was raised, bloods were unremarkable, and ECG was non-specific. We could not distinguish if it's like S1Q3 pattern. And like on AVG, there was hypoxia, hypocapnia, and increased alveolar arterial gradient. So this is the ECG of the patient. I'll give you a few seconds to have a look at it. So what's your likely diagnosis, guys?
Looks like P.
Yeah, clinically, and yeah, Dr. Shil, it looks like a PE. So we also decide to do a scan, but the patient was too unstable for a CT or VQ scan. So cardiology not available, and radiology was also not available. We decide to do ultrasound, ED, point of care ultrasound. So we try to look for lungs, IVC, heart, and leg and veins. These were the findings. So lung was clear on the ultrasound, and inferior vena cava was non-collapsing on the scan, and right ventricle was more dilated than left ventricle. And on examination of the calf veins, there was signs of DVT. So what's your likely diagnosis? So lungs are clear, distended IVC, high pressure dilated right ventricle compared to left ventricle, DVT present. So the diagnosis would be massive PE, and the treatment will be prompt ED thrombolysis, and there will be rapid improvement in the patient. So with that, let me discuss about a nice guideline on thromboembolism diagnosis and anticoagulation treatment. Any question up to now, guys? Okay, I'll take that as no. So let's proceed with the nice guideline on venous thromboembolism diagnosis and anticoagulation treatment. Before proceeding with that, we should know how to calculate well score for a DVT. DVT. So usually for active cancer, we have 1 point. For a recent immobilization paralysis, we have 1 point. If the patient is bedridden for more than 3 days, it's 1 point. For localized tenderness along the distribution of the deep venous system, it's 1 point. If the entire leg is swollen, it's another 1 point. If there is calf swelling at least 3 centimeters larger than the asymptomatic site, for the 1 point. So if there's pitting edema confined to the symptomatic leg, it's 1 more point. If there is a collateral superficial vein, then it's 1 point again. And if there's a previously documented DVT, then it's 1 point. And an alternative diagnosis is at least as likely as DVT. If that's the case, then it's -2. So we have to total the points, and then the DVT likely. If the points is 2 or more, then its DVT is likely. And if the point is 1 or less, the DVT is unlikely. So that leads to I made a flow chart from the NICE guideline. So to diagnose suspected DVT. So we have suspected a DVT. So we have to, I said earlier, determine the 2-level DVT well score. So we can have 2 answers. If the well score is more than 2, that is DVT is likely. If the score well score is less than 1 point, that means the DVT is unlikely. So if the well score is more than 2 points, DVT is likely. So what we have to do next is we have to do proximal leg vein ultrasound scan within 4 hours. And also what we can do is D-dimer test if not already done. And we have to start patient on interim therapeutic anticoagulation, and we have to scan the patient within 24 hours. So what if the well score is less than 2? So we have to do D-dimer test within 4 hours, and we have to give interim therapeutic anticoagulation while waiting for the test result. So what if the scan comes positive? So a diagnosis of DVT is established, and we have to continue the treatment. And what if the scan is negative? So we have to do quantitative D-dimer if not already done. And there's a 2 situation again, there's D-dimer positive and D-dimer negative. So if the D-dimer is positive and scan is negative, then what you can do is we have to stop any anticoagulation and repeat the scan in 6 to 8 days. So if the D-dimer is negative, in this flowchart, we have to stop any anticoagulation and think about other possible diagnosis. And like if the we do the second scan after like 6 to 8 days, if the second scan is positive and second scan is negative, we have two scenarios again. So if the second scan is positive, like a diagnosis of DVT should be established, and we have to again commence the patient on treatment again. And if the second scan is negative, like like I said earlier, stop any anticoagulation and think about other diagnoses as well. So this is the flow chart for like management of DVT, like diagnosis of DVT and initial management according to NICE guideline 2020. So yeah. So like let me go to the PE well score before I proceed with the diagnosis of PE. So like this is somewhat like the DVT score as well. So like we have to look for like clinical signs and symptoms. So like if we have like clinical signs and symptoms of DVT, then it's like the patient will score 3 points, and alternative diagnosis of P is less likely than further 3 points. If the patient is tachycardic, another 1.5 point, and if there's like immobilization for like more than 3 days, then score of 1.5. And previous history of DVT and PE will score 1.5 as well. History of hemoptysis will give 1 score. And if the patient has a malignancy on treatment and treated in the last 6 months or palliative, so it gives further 1 point. So more than 4 points, PE is likely, and 4 or less point, PE is unlikely. So that will lead to like me telling you about this suspected PE diagnosis and initial management flow chart, which I adapted from NICE guideline 2020. So if you suspect PE is suspected, then like we have to initially like do the PE well score, like I said earlier. So there will be 2 scenarios again, like a score less than 4 and score less than more than 4 and less than 4. So if the well score is more than 4 point, PE is likely. So we have to do immediate CTPA. Interim like therapeutic anticoagulation should be started immediately while we are waiting for a CTPA. And if the CTPA is positive, a diagnosis of PE established, and we have to offer like continuous treatment. And if the CTPA is negative, and we have to like scan for DVT, and like we have to consider proximal leg vein ultrasound. And if the DVT is not suspected, then we have to stop any anticoagulation and think about other diagnosis. So if the well score is less than 4, PE is unlikely. But however, like we have to like do the quantitative D-dimer test within the 4 hours, and like we have to like start the patient on interim therapeutic anticoagulation while we are waiting for this result. If the D-dimer is positive, so we have to again like scan the patient, like we have to do immediate CTPA. So if the D-dimer is negative, we have to think about like any other diagnosis. So this is like a summary of the NICE guideline on suspected PE diagnosis and initial management. So like after we like diagnose a patient to have like a DVT or PE, so we have to like if we haven't already done, we have to measure full blood count, renal and hepatic function, PT and APTT. And we have to offer anticoagulation for at least 3 months, which will be done by the a GP or a medical team. So this is the summary of the dose of like anticoagulant like we should prescribe to the patient. The first one is being like for generally healthy people. The second one was with a renal impairment, and the third column is for like active cancer, and the fourth one is for like antiphospholipid syndrome. So you can go through this. I won't read through this. So these are my references. So recommendation, like in shock, like time is life. So we have to like, act really fast. Patient might deteriorate and we might lose the patient. We have to like think always aim for goal directed therapy. As a trainee, we should use well score and NICE guideline for VTE, and we should use the like a venous thromboembolism diagnosis and anticoagulation treatment. Thank you.